My name's Julia Newton. I'm Medical Director at Health Innovation North East North Cumbria, and it's my pleasure this lunchtime to chair this session. And we're joined by a couple of speakers who I'm absolutely delighted have taken the time out of their very busy days to come. So for those of you that are not aware of what a health innovation network is, we used to be called Academic Health Science Networks. We changed our name a few months ago to Health Innovation Organisations, and we're Health Innovation North East North Cumbria. We cover the geography of our ICB, about 3.2 million. And we're almost unique in the fact that we align geographically exactly with our ICB. You can see on this map here the other health innovation organisations, and we all collectively across the 15 work together in order to boost and evidence-based practice, spread innovation, and to share. And this is an opportunity of how we do that. For us, in the health innovation organisations, we have a CVD portfolio that is now being delivered across the 15 organisations. And within that, one of the relatively new areas that we're focusing on is chronic kidney disease, partly because of the huge cardiovascular risk that is associated with having that condition. It's a new departure for us in North East North Cumbria. We're really excited about this, but are becoming aware that that we need to raise awareness of chronic kidney disease, hence this webinar today. At the same time, our new clinical strategy that's been developed by our ICB has got a real focus on cardiovascular disease, and within that, similar to the health innovation organisations, that there is a big focus on chronic kidney disease. So we're very much working as a system to deliver the projects in our CVD portfolio, but in partnership with our ICB and the Renal Clinical Network. So it's really exciting for us to be able to bring you all together today with such eminent speakers. So I'm going to hand over now to Professor Raj Thacker, who is a GP at Bourne End and Woodburn Green Medical Centre. He's president of the Primary Care Cardiovascular Society and their CKD lead. So we couldn't have asked for anybody better to be with us here today. He's also got a national primary care role as the workstream lead for cardiac transformation programme with NHS England and Information. So I'm honoured and delighted that Raj is joining us today. And I'm going to hand over to Raj for the first part of this session. He's going to give us a really fabulous background. I've heard him talk on this topic before, so I know what's coming. So thank you, Raj, and I'll hand over to you.
Thanks, Julia, for that lovely introduction. It's a real pleasure to be talking to you all today. Really excited that CKD has a rising profile across the NHS. I think it's kind of been the Cinderella risk factor for cardiovascular disease for so long. And so, very, very excited that we're raising the profile and flying the flag. I'm really going to be covering today the link between cardiovascular disease and chronic kidney disease, and I'm hoping that by the end of this session that we'll all go away having changed our practice and doing something different for our patients and proactively identifying CKD and then optimizing those patients to reduce their risk. There are my declarations. So what am I going to be covering today? I'm going to be covering CKD as a risk factor for cardiovascular disease, the importance of ACR testing. So I'm going to be talking about albumin to creatinine ratio testing. And if we don't test the ACR, then we will underdiagnose CKD. And if we don't test the ACR, then we will underestimate the prevalence of obviously that condition, but the severity of CKD as well. And therefore our patients might miss out on guideline-based therapies and some QI tips that we can take home to our practices. So let's go right back down to the beginning. what is CKD? And this is really described by KDIGO, that's the Kidney Disease Improving Global Outcomes International Guidelines Group. And they define CKD as two things. It's one, there's damage to the kidneys, and that's mainly by the presence of albuminuria in the urine. But of course, it could be structural kidney disease, it could be radiological disease, it could be histopathological disease. But for our purposes, it's albuminuria and I think that's a really critical word here, a decrease in kidney function, so a decrease in EGFR. And these have to be present for at least 3 months, and that will cater for those transient changes in kidney function. For example, if someone's got a UTI or they're given trimethoprim or another transient reason. So let's keep that in mind and move on and just go on to the epidemiology of CKD. So it's a really common condition. It's going to be by 2040 the 5th rank cause of death in the globe. If you can put off your mics, that'd be great. Thank you. So if you look at some of the data in the UK for an EGFR of 60 or less, there's around 3.6 million people, and of course that's going to increase over time. A third of people with CKD are undiagnosed, and that's a really important issue, because if you're undiagnosed, then you're not on a disease register and you're more likely to end up in hospital with a CVD event or an AKI event, and there's an increased mortality risk with that issue as well. So it's very, very important that we identify and code CKD properly, and that was borne out by the CKD audit from 2017. So it's well worth reading the CKD audit from 2017, which describes the importance of coding in our systems. And for those people who work in primary care, the CQC often look at your coding of CKD as a QI project. There's also a significant inequality gap. So if you're South Asian and you have diabetes, you're 10 times more likely to end up with end-stage renal failure than if you're Caucasian. So that's another great QI project for your practices. Let's take a step back further and look globally at the prevalence of CKD versus diabetes and heart failure. We can see here that CKD will absolutely dwarf diabetes and heart failure in terms of prevalence. But the other couple of points I wanted to bring out from this slide is that CKD often occurs without diabetes and heart failure, although diabetes is the commonest cause worldwide. And of course, there's often the multimorbidity axis. So if someone has diabetes, they're far more likely to have CKD. If someone has CVD, they're more likely to have CKD. So it's really important that we're, when we're managing these patients, when we're thinking about our diabetics, we should also be thinking about CKD. When we have a patient with CVD in front of us, we need to be thinking about CKD. So one of the key messages I want us all to take away is that we need to be thinking more proactively about our patient in front of us. Do they have chronic kidney disease? And if not, how do we assess the fact that they've got kidney disease or not? Let's look at the health economics of CKD. So this is a slide which summarizes a paper by Marion Kirsch, as a health economist, and she looked at NHS data from 2009-10, and she found that CKD was independently accountable for an excess 7,000 strokes and 12,000 MIs in that year alone. That cost the NHS 1.45 billion and added 35% to hospital length of stay. So the message here is that we must identify people with CKD at an early stage and optimize them to reduce the risk of cardiovascular complications and hospital admissions. How do we diagnose and classify CKD? Well, remember, we've talked about EGFR and ACR. And what you've got in front of you is the KDIGO heat map, which is then in NICE. And you can see the rows there, which represent the EGFR on a sliding scale from G1 right down to G5. And if you look at the columns, they represent the ACR, A1, A2, A3. That's less than 3 to 30, and greater than 30 milligrams per millimole. And the colours represent risk, and that's risk of all-cause mortality, end-stage renal failure, and cardiovascular disease. And if you look at the green, that's not That's not no risk, that's low risk. And then we've got medium, high, and very high. Right, keep that in mind. So what does NICE say in whom we should look for a CKD in? So we should use eGFR and ACR to look for a CKD in high-risk groups. So diabetics and hypertension, that makes sense. That's the top 2 causes of CKD globally. Anyone with a history of AKI, anyone with a history of cardiovascular disease, and I think that should include valve disease as well as stroke. Then we've got any structural kidney disease, gout, lupus, obviously, and inherited diseases too. So we might want to think about how we systematically should identify CKD in our patients and proactively do that rather than reactively. What system are you going to put in place to use eGFR and ACR to identify CKD in your patients and then optimize them accordingly? Right, so let's link CKD with CVD. This describes the audit from 2017, which I described earlier from the London School of Hygiene and Tropical Medicine. And it says for every 100 people with moderate to severe CKD, there are 38 unplanned admissions per year. So for people who are involved in system change, leadership, want to do something differently, want to put their head above the parapet, think about CKD as a great project in order to help system resilience. But also in terms of your individual patients, you might be able to avoid a CVD event, an ITU admission, an unplanned admission, if you detect and code the CKD appropriately using eGFR and ACR, and then, of course, optimize that patient accordingly. Right, let's get under the bonnet of this. So I want us to think about kidney disease and kidney health as a lens into the cardiovascular health of the body. So the heart and the kidneys talk to each other. They are not independent organs. We know that the kidneys receive around 20 to 25% of cardiac output. We know that the nephrons are very susceptible to ischemic change. So we must really think about the kidneys in terms of cardiovascular risk. The other point I wanted to get through from this slide is that if you have CKD, you are 20 times more likely to die from CVD than you are of end-stage renal failure. So it's mission critical now we start to think about kidney disease as a cardiovascular risk factor. It's not a separate entity that we should ignore, but we need to be thinking proactively about how we identify these people using NICE NG203 list, which I talked about earlier, and then optimizing those patients, which I and Sarah will cover a bit later. Okay, let's convince you more. CKD versus diabetes. So this highlights a paper from the US. It's by Foley from in 2005. And he looked at over 1 million people in the US and compared diabetes and CKD. So at the bottom, we've got chronic heart failure, acute myocardial infarction, stroke, peripheral vascular disease and death, and we've got incidence on the y-axis. So we've got the baseline incidence here in patients who don't have diabetes and don't have CKD. We now have patients with diabetes in the amber, and we can see there for all of those domains, unsurprisingly, there's an increase in incidence. But what about CKD in patients who don't have diabetes? So that's a dark blue bar, and we can see for people with CKD who don't have diabetes, there's a much higher incidence of heart failure, myocardial infarction, stroke, peripheral vascular disease, and death. So I'm hoping that will convince us all how important it is that we need to be focusing on CKD as an independent and powerful risk factor for cardiovascular disease. And of course, if we combine CKD and diabetes together, there's a synergistic risk. Okay, so diabetic kidney disease, the commonest cause of CKD worldwide. It's a common condition. A significant number of patients with diabetes will have diabetic kidney disease, around 40%. Around a quarter of those people will have albuminuria A2 and around 8% A3, depending on a number of factors. Happens for a number of reasons, but we get some glycosylated lipids and other proteins damaging the kidneys. We get a RAS activation, so we get sympathetic activation, we get inflammation within the kidneys, we get sclerosis and fibrosis, and we want to avoid that from happening in order to to avoid the complications of diabetic kidney disease. It's also important to remember here that in diabetes, you get a paradoxical increase in eGFR to start with to compensate for the damage, but that is a pathological increase in eGFR. So in our patients with diabetes, you might not want to be reassured by having a normal eGFR in those patients. Right, a little bit more under the bonnet. So the cardiorenal syndromes, if a patient has diabetic kidney disease or any form of kidney disease, that can damage the cardiovascular system. So you get hypertension, partly because you get very calcified, stiff arteries, you get valve disease, again, because of calcification. So around 30–40% of patients with stage 3 CKD will have aortic stenosis, and over 90% of those patients with stage 5 disease will have aortic stenosis. So again, a nice QI project will be to be looking for valve disease in your patients with CKD. That makes a lot of sense because, of course, we know that people with even asymptomatic valve disease have an issue with their mortality risk going forward. And so if you look at Oxvalve study, for example, we can see that people will have a significant reduction in their life expectancy if they've got asymptomatic valve disease. So it's very important that we look for valve disease in these patients. So then there's a risk of heart failure in patients with CKD, and of course an increase in stroke and vascular disease, and an increase in arrhythmias, including sudden cardiac death. So a number of people, around 50% of people who are on dialysis will actually die of a CVD event. Okay, going back to our heat map. So if we don't check for albuminuria, we can underdiagnose CKD. So you can imagine our patient who's got a normal eGFR. Remember, we talked about diabetes with an increase in eGFR before it decreases. So if we don't check for albuminuria, our patients might be underestimated, or you might underdiagnose the presence of CKD. Also, if you don't check for albuminuria, you will underestimate severity for that patient. So you can imagine here, patient with stage 3 CKD, you might think they're at medium risk, but if you check for albuminuria, you might find that actually they are at severe risk. So that's a really important factor to think about, and should persuade us all that we need to be checking for albuminuria, not just eGFR. And of course, finally, we need to check for albuminuria because our patients might qualify for guideline-based therapies such as SGLT2 inhibitors and finerenone. Right, complicated slides. Let me just navigate you through this. Again, this should persuade you to check for albuminuria. On the left-hand side, these are going to be looking at all-cause mortality. In the middle tile, that's cardiovascular mortality. And on the right-hand side, that is renal failure. And if you can imagine, or just look at stage 3 CKD across the bottom of this of these tiles, we can see that if you compare an A1 to an A3 patient, that increases CVD mortality by 300%. So again, a very powerful argument to make sure we check for albuminuria in our patients. Okay, so what can we be doing in the primary care space to ensure that we optimize our patients? Well, we need to be looking for CKD to start with. We must use the eGFR and ACR test. We can't just rely on eGFR alone. And we must code patients for CKD. That's a really important factor. That's come through from the renal audit from 2017, as mentioned earlier. And of course, if you're worried about workload, then focus on those patients with the greatest inequalities first. And you can use a CVD action tool when that comes out to help you do that. Then in terms of management, we need to educate our patients. They really need to see the value and understand the value and purpose of identifying CKD, and educate our colleagues. Think about lifestyle management for these patients. So it's not just all about drugs, but lifestyle is really important: smoking, obesity, alcohol, etc. Think about QRISK-3. I'm going to talk about that in a second. And the kidney failure risk equation, Sarah's going to cover that in her talk. And then in terms of meds management, lipid lowering therapy, that's in QoF, that's in COL 001. So anybody with CKD should be offered lipid lowering therapy because it's a cardiovascular risk state. Max RAS inhibition to get the the glomerular pressures down, SGLT2 inhibitors and finerenone where appropriate, optimizing the long-term condition that's caused the CKD to start with, and think about frailty. And that's really important. So we've been talking a lot about frailty at national level, to think about those personalized care discussions for our patients, identify them if they're over the age of 65 using the clinical frailty score, because those patients will need personalized care discussions. And we know from some of the papers, from the Mooney paper from 2013, for example, that in patients who have severe frailty or are over the age of 80, then renal replacement therapy might not confer a benefit. So we really do need those individualized care discussions in patients with frailty or, of course, are in the last year of life. Right, QRISK 3. So this is just a little bit of a health warning around QRISK. So you can see in front of you that obviously QRISK 3 has a box for CKD, and that's for CKD stages 3, 4, and 5 in one box. But there is a 10-fold mortality risk difference in terms of CVD mortality between stages 3A and 4. So we just need to have that little health warning about QRISK 3 because it might underestimate a patient's risk. And of course, QRISK 3 doesn't include an ACR. So the message here is if someone's got CKD, then they are automatically at high risk of cardiovascular disease. Remember, we've talked about the fact that if somebody has CKD, that's a cardiovascular risk state, and that's why all of these patients should be on lipid-lowering therapy. We need to be thinking about all of their cardiovascular risk factors. So don't base your statin prescribing on QRISK 3. Okay, the KFRE, that's going to be covered by Sarah, so I'm not going to discuss that any further. I don't want to steal her thunder. SGLT2s in diabetes. So let's get under the bonnet of how these work. On the left-hand side, we can see the tubular-glomerular feedback loop, and the proximal tubule is where the SGLT2 receptors are. In diabetes, there's an upregulation of those receptors, so there's an increase in reabsorption of glucose and sodium. So in the macula densa, we'll sense that there's not much sodium in the filtrate and will therefore dilate up the afferent arteriole to compensate, and that will increase the eGFR, giving you that false reassurance that everything is fine in the kidneys. But then obviously that feedback loop is readdressed by giving an SGLT2 inhibitor. What can we be doing in terms of QI in CKD? Well, we need to be coding our patients. I think it's a really important project in the primary care space. Again, that's evidence-based. And if we increase the coding and therefore increase the prevalence of our CKD, that patient is on the register. You can then recall and review them, but there'll also be flags on the system.
Oh, you've got contributory.
So can we just make sure we're all on mute? So if we make sure that those patients are coded, of course, then we've got a system where we can have flags on the GP EPR that will avoid us giving nephrotoxic drugs. And of course, we can think about cardiovascular risk in those patients. We need to actively look for CKD using eGFR and ACR. Remember, that's based on NICE guidance. We can listen to heart valves. That's a really nice project you can do in primary care. We're just about to kick off a study doing that. Think about heart failure, because we know there's a significant link between heart and kidney. And then in terms of management and a QI project, you can look for albuminuria and manage those patients with albuminuria, because if you reduce the albuminuria, you reduce the cardiovascular risk. So the albuminuria is a lens into the cardiovascular health of the body. And of course, we know from the Renal data, so post hoc data from the Renal study many years ago, that if you reduce albuminuria, you reduce cardiovascular risk. Think about CVD risk factors at an early stage. So remember, heart disease, heart attacks are a lifetime in the making. We don't want to wait until someone's already had an event. We need to be thinking about cardiovascular risk at a much earlier stage. And obviously that's just come out in the new NICE guidance on lipids, thinking about cardiovascular risk even as low as age 25. Optimizing secondary prevention in patients who've already had a cardiovascular event, that's really important in terms of a QI project. And of course, if you're interested in frailty, you might want to think about frailty as a QI project in your area of work. So let's summarize before Sarah takes over. CKD is a massive risk factor for cardiovascular disease. It's a stronger risk factor than diabetes. We've talked about that in the Foley paper. We need to be thinking about proactively identifying CKD using NICE guidance, that NICE list of patients at risk of CKD, using EGFR and ACR. We can't just rely on EGFR alone. If we don't use ACR, we'll underestimate the severity of CKD, and our patients might miss out on guideline-based therapies. We'll also underestimate the prevalence of CKD as well. Very important to code, and we need to be thinking about the cause of the CKD, think about lifestyle management, and then drug control, max RAS inhibition to reduce the glomerular pressure. So it's not just small doses of ACE or ARBs, but really optimizing max tolerated doses to get the glomerular pressure down. SGLT2s where appropriate, finerenone where appropriate. So for those who don't know, finerenone is a non-steroidal mineraloreceptor antagonist, and it's licensed for type 2 diabetes with stage 3 or 4 CKD with albuminuria. Also lipid-lowering therapy and getting the blood pressure right down to safe levels, and think about frailty in these patients. So hopefully that will give you a flavour of the importance of CKD. The Primary Care Cardiovascular Society has a QI programme you might want to look at in terms of chronic kidney disease. So feel free to become a member of the PCCS. That's at pccsuk.org. Sarah, I think over to you.
Brilliant. Thanks, Raj. That's great. It's just Julia very quickly. There are some questions coming in, but we'll come to those at the end. And we're just going to hand over now to Dr. Sarah McCloskey, who is a consultant nephrologist at South Tyneside and Sunderland NHS Foundation Trust and the CKD lead for the North East and North Cumbria Regional Operational Delivery Network. So thanks so much, Sarah, for coming along, and over to you now.
Thanks, Julia. And thanks to Raj for setting the scene very, very nicely. Today I'm going to focus more on the secondary care aspect and that link between primary care and secondary care in terms of monitoring and referral of CKD. I think Raj has very nicely highlighted how much of an issue that identifying and acknowledging and intervening early in the span of CKD is, and how that, and I'll cover in a bit more detail how that interlinks with us in secondary care. So we've heard lots about the population aspect of CKD and the cost to the NHS and the implications, but what we really need to remember is actually at the end of this there is a patient, and unfortunately CKD, you know, it's a diagnosis that does not tend to improve. It's a lifetime illness that stays with the patient, and at all stages of CKD we know that this has a significant impact on patients in terms of their quality of life and then also on their mental health. Unfortunately, most patients with advanced levels of CKD experience reduced employment prospects, and that's particularly notable in our dialysis populations. So, for example, a dialysis patient that is receiving hemodialysis will on average attend hospital for 3 dialysis sessions per week, and they are sessions that last around 4 hours for each session of treatment. That doesn't include their travel to and from hospital. So essentially for most patients, either on a Monday, Wednesday or Friday, or a Tuesday, Thursday or a Saturday, most of their day is spent traveling to and from hospital, accessing that treatment and having that treatment delivered. So yes, we for our younger patients, we are able to offer evening dialysis sessions to help improve things, but you can imagine the significant impact that that has on their lifestyle, their ability to maintain and hold down a job, and then also the impact on their wider family as well. And what we do know as CKD progresses as well, and particularly for our dialysis patients, it has significant impact on their fertility, which again then has knock-on impact and issues for future planning for these patients, all leading to a kind of a melting pot of a increased risk of anxiety and depression, and then lower quality of life scores for patients, particularly dialysis patients. So if there's anything that we can do to intervene earlier to prevent these patients from progressing to end stage, then that has to be a good thing. And what we're aiming to do is to get to patients at the earlier stages of CKD with newer medications and interventions that allow us to essentially, what we're hoping to do is either prevent them from reaching end stage at all, if that's possible, or just increasing that time to when they reach those more advanced stages of CKD and become symptomatic, and it starts to have an impact on their physical and mental health. Raj has already spoken about some of those medications. This is a graph showing the impact that starting dapagliflozin has on a patient's rate of progression of CKD. So you can see there the blue slope shows a leveling out of their eGFR after an initial small drop in function, but this long-term beneficial effect prevents progression of CKD over time, and that's really what we're looking for to establish in all of our CKD patients. And there's an increasing body of evidence now that this isn't just for dapagliflozin, that this is a class effect across all of the flozins. And we've talked, or Raj talked to you about frailty and how, yes, patients who are older do not do well on dialysis. Unfortunately, the lifespan of an elderly patient over the age of 75 to 80 on dialysis is significantly reduced to around about 3 to 5 years. So the prospects of survival for those patients, if they actually reach end-stage renal failure, is actually quite poor. This graph is taken from a study of diabetic kidney disease, and you can see that if we intervene in a patient in the earlier stages of CKD with an eGFR of above 60, we can potentially prolong that period of time before they reach end stage by about 11 years. And for a 70-year-old, that might mean the difference between them reaching end stage in their 80s versus reaching end stage in their 90s. However, if we don't intervene at those earlier stages and it's left until their eGFR drops to around about 30 or below, you can see even intervening at that point for a 70-year-old unfortunately only delays their progression to end-stage failure by about 3 years, which would mean they would then fall into that category of very elderly population that started on hemodialysis or peritoneal dialysis and has that much more significantly reduced lifespan. So this is a plea to identify those patients as early as we can. And NICE has recently rewritten their guidelines to help identify those patients that should be screened with both eGFR and UACR, and has also given us some really useful tools for identifying patients at a bit of an earlier stage that wouldn't necessarily fall into the what you would think would be the usual categories of referral to secondary care. Raj has already touched about the importance of statin treatment, cardiovascular disease being that force multiplier, vice versa for CKD, and then the importance of SGLT2s, which we'll talk about a bit in a minute. So NICE suggests that these are the following patients that should be screened for CKD. Anybody who has risk factors. So those patients who are on nephrotoxic medications, and by those we mean non-steroidal medications or calcineurin inhibitors such as tacrolimus, cyclosporin, should be screened on at least an annual basis. All diabetics, hypertensives that are in that long-term condition review process are at significant risk, and screening those patients regularly with eGFR and ACR levels. Patients with hypertension, anybody with an acute kidney injury, and those patients who have had significant acute kidney injury, i.e. stage 3, need to be screened on an annual basis for probably around 5 years after their initial AKI. And that may not always happen in a secondary care setting. Quite often we do see some patients who have had significant AKI discharged back into the community because their kidney function has returned to completely normal, but they are at an increased risk of developing CKD later down the line. Cardiovascular disease, anybody who has structurally abnormal kidneys, so one kidney, two kidneys that are abnormal shaped or positioned, horseshoe kidney, for example, or renal stones, are at risk of developing CKD down the line. Multi-systems disease, and then we're starting to get now into an overlap of those patients who actually should probably be referred more readily to secondary care, as well as just being screened on an annual basis. So I've not actually got a slide on who needs to be referred to secondary care, but we'll touch on the kidney failure risk equation in a minute. But that has replaced the standard GFR cutoff, which was previously quoted by NICE as anybody with an eGFR less than 30 automatically should be referred to secondary care. The patients that we want to see are those with a reduction in kidney function and a family history of hereditary kidney disease or end-stage kidney failure resulting in renal transplant or dialysis. Those patients who have got significant proteinuria, so UACR of over 70 milligrams per millimole or more, unless specifically and already known to be due to diabetes. A sustained decrease in eGFR, so that's usually a 25% drop or greater within 12 months, and that hasn't recovered. So an eGFR of that's been reduced on repeat testing, and then a suspected rare or genetic cause of CKD, usually indicated by past medical history or significant reduction in kidney function. So I've mentioned this a couple of times now. This is the kidney failure risk equation. This is a 4-variable equation that was initially developed in America, but has been applied and validated in a UK primary care population. And what this does is takes into considerations a patient's sex, their age, their kidney function based on their eGFR, and then also the degree of albuminuria. It's a fantastic website and I really like it. It's nice and visual, and it's a really good way of talking through kidney disease and then kidney risks with patients in the room with you. So what I would say is, just when you are accessing this, make sure that you click on the .co.uk version to ensure that you get the one that's been validated in a UK population. So this is what it looks like after you enter the patient's details. So at the top you can see that we've chosen a patient who has a reduction in their eGFR but a severe amount of albuminuria based on that A1 to A3 category. On the right hand side you're given two figures. So the first figure is the risk of progression to end-stage kidney disease at 2 years, and then the second figure is at 5 years, and that for this gentleman who actually doesn't have a massive reduction in their eGFR, it demonstrates still that there's a reasonable risk of progression to kidney failure at 5 years, and that's 6.5%. And this is important because NICE has now incorporated this into their guidelines for who should be referred to secondary care. So this suggests that anybody with a KFRE of over 5% at 5 years should be considered for secondary care referral. And that's considered, you know, this isn't a one-stop shop for everybody. We acknowledge that some elderly patients who have that age-related decline in eGFR and then often have a skewed albumin-creatinine ratio because of low urinary creatinine may have a KFRE that then overestimates their risk. And also we acknowledge that an older population may not necessarily be suitable for referral into secondary care based on significant frailty, terminal conditions or comorbidities. So this really needs to be kind of a shared decision-making process with the patient based on their wishes and what they want. But what this is hopefully designed to do is to pick up those patients that wouldn't necessarily fit into those other criteria of that you would think it was kind of would trigger a secondary care referral based on classical characteristics. This website I find is really quite helpful because of this next bit. So in the green, you've got the patient's total initial calculated risk, and then the right-hand side there, it allows you to click on the individual interventions to see how much it can reduce a patient's risks by. So for this patient who has a moderate to severe amount of albuminuria with a reduction in their eGFR, by maintaining good blood pressure control, we can already reduce their risk. By maintaining good blood pressure control by optimizing their RAS inhibition with either an ACE inhibitor or an ARB, we can significantly reduce their risk. And then in addition to adding in an SGLT2, you then reduce that risk by nearly half. And I love this because it gives a great visual representation to say, look, I know I'm asking you to take lots more new medicines, but this is how we can significantly improve your outcome going forward. And you know, it's an excellent visual aid, I think, for patients who may not be happy considering percentages and numbers, but just look, we've almost reduced your risk by half here. So speaking about those medications, the importance for us is to have those patients who are identified as being high risk optimized with that stepwise approach of ACE inhibition, maximizing their ACE inhibitor ARB, and then the addition of SGLT2. And we know that that can sometimes be a bit of a scary prospect. There are new medicines, and quite often there's lots to talk about in terms of counselling the patients appropriately on potential side effects, including some rare and quite serious side effects. But in the Northeast, we're really lucky that we've developed some really helpful literature. So this is an example of the multi-condition SGLT2 visual guide for primary care prescribers for SGLT2s. So there's a lot of them now on the market. They each have their very nuanced indications for long-term conditions, including heart failure, diabetes, with different eGFR cutoffs and UACR cutoffs, which can be quite confusing. But this document gives a really helpful visual guide as to which is the SGLT2 that you need for your patient based on their interacting comorbidities. I've not shown it, but the second part of the document gives a really useful guide as to the eGFR cutoffs that they can be prescribed at, and then also takes you through that process of monitoring and counselling the patient appropriately. In addition, we've also got this fantastic patient information leaflet as well, which essentially covers everything that you would usually counsel the patient on in terms of side effects and sick day rules, and that can be downloaded, printed out, and given to the patients as a aid memoir when they leave you. So that's everything that I'm going to touch on today. Hopefully both Raj and I have kind of emphasized to you the importance of early intervention, how CKD and CVD both go really hand in hand, and the importance of treating and monitoring for both, and then a few helpful hints on how and when to refer to secondary care and how to take things forward in primary care. Thanks.
Brilliant. Thank you, Sarah. That was absolutely fantastic. And thank you, Raj, for putting all those great resources into the chat. So, you know, I point everybody who's listening to the chat to have a look at resources linked to the PCCS and to Clinical Digital Resources Collaborative for anybody looking for search tools that are being well used already to increase coding in CKD. So we're going to have some questions now. So if anybody has a question that they would like to pose to Raj and Sarah, please, if you could put your hand up, that would be brilliant. But in the meantime, we've got a question from Gordon Chia. Some practices do UPCR rather than UACR for non-diabetic patients to screen for proteinuria. What's your thoughts on this? Should UACR be done rather than UPCR, or are they just the same thing? Sarah, do you want to answer that one?
Yeah, I can jump in on that one. UACR is a component part of UPCR and is therefore probably slightly more sensitive as an early marker of kidney damage. So the equivalent a UACR of 30 is roughly equivalent to a UPCR of 50, but quite often small amounts of albuminuria are one of the first signs that there is issues with the kidney. As Raj said, you might be falsely reassured that the patient doesn't have any kidney disease because their eGFR actually goes up in the very early stages of diabetic kidney disease, but quite often, despite that supranormal eGFR, the UACR is often elevated. So in the early stages, in terms of a screening test, we would always advocate UACR. We tend to use UPCR in secondary care for more advanced or established kidney disease.
Brilliant. Thank you very much. Anything to add to that, Raj, or was that everything from your perspective?
No, I was going to say the same thing. Absolutely. It's a UACR that's more sensitive. That's what we should be using in primary care. Right. And obviously, the more complex patients, once they're under the care of people like Sarah, that's when the UPCR comes into play. So from the primary care space, ACR is the way to go.
Great, thank you. And then Carol, you've got your hand up. If you could unmute yourself and ask your question, and take your camera off if you don't mind as well.
I'm afraid I can't take my camera off because it's not working very well, but can you hear me all right?
Of course, yeah. No, that's great.
Yeah. It's just a little query. I mean, I know the guidelines, of course. I've worked with CKD for a long time, and I know the guidelines say you have to wait 3 months to see that that's chronically reduced eGFR before you label as CKD. I think my fear is just that we actually lose people. So I think in very practical terms, would we be okay checking an eGFR, say, after 2 months rather than 3 and coding? And my worry is that if we wait 3 months, we lose the patient, they forget they need the test, many practical problems in it, and that actually we then don't detect it and we end up seeing them again after a year. We just have a very big patient population, and it's very hard to actively call in for every single interim test that we need. So just what's your thoughts on that?
Raj?
Yeah, I think it's a good question. Obviously, the definition says 3 months. I think on a practical level, after 2 months, if the patient's well and any cause of a transient reduction in eGFR is corrected, whether it's trimethoprim or dehydration or intercurrent illness, UTI, etc., all of these things, if they're corrected and you check it at 2 months and the eGFR is still low, or they've still got persistent albuminuria, then I don't think it's unreasonable to diagnose CKD. I think for me, it's better to diagnose it and manage that patient than to not diagnose it, and then that patient gets lost to follow up. If you want to be, stick directly to the guidance, then clearly it's 3 and the definitions, it is 3 months. But I think you've got to be practical. But equally, a practice system of calling someone in 2 months rather than 3 months, I can't really see much difference on a practical level. There's still difficult things to do, especially because it's a silent killer in a sense. People don't know they've got CKD necessarily.
And then I'd rather sort of remove them from the register easily, of course, if it bounces back up after that. And also just to check, how imperative is it to check the urine or for dipstick for blood at the point of diagnosis? Because I know a lot of surgeries don't do that, and I think the guidelines suggest that, don't they? How imperative would you put that in to practice? Do you think that's a biggie?
Sarah? Can I answer that one? Yeah, can I answer that one, Raj? So yeah, it is in the guidelines, and that's because I think, unfortunately, 1 in 5 patients with non-visible hematuria will, over the age of 45, will end up being diagnosed with a urological malignancy. So it's picking up those patients earlier, and that's a slightly separate issue to the CKD. But all of those patients should probably go down a urological assessment route first, prior to then being referred to nephrology. So I think it's really important that that is still done, and it also then helps us in secondary care, and hopefully you as well, at the presence of proteinuria as well as non-visible hematuria in the absence of a UTI, is also a further indication for referral.
So the main indication for the dipstick is more to exclude those people with malignancy rather than any particular bearing on CKD. Is that right?
Yes. That was the sense I got from Sarah.
So much for those answers. Brilliant. Thank you.
Brilliant. We've got a question in the chat from Tracy Marshall. Is there a drug and dose of choice for lipid lowering medication in CVD primary prevention patients with CKD? Raj?
So I'll take this. Yeah. So if you look at the NICE guidance, it will be a 2 over 20 will be the standard for primary prevention. But clearly, if they can't tolerate that you need to tailor it accordingly. So for primary prevention, you want to get the LDL to 40% down from baseline, assuming they don't have FH. The important bit for me is you get the CVD risk down as much as possible, including lipid-lowering therapy, blood pressure control, etc. If they can't tolerate a statin, or if they can't tolerate a torvastatin 20 milligrams daily, you might want to give it alternate days or a few times a week, or use a less intensity statin like pravastatin, or a non-statin based therapy such as ezetimibe. I think the important bit for me is to get the cholesterol down and reduce their cardiovascular risk.
Right. Thank you. And then Yvonne's asked a really good question. If a patient with G3AA1 for a year after losing weight and EGFR then improves to 80 plus, persistently without albuminuria, when would we class them as resolved, or do they remain on the CKD register indefinitely? Raj?
Yes, it's a very good question, actually. I don't know the answer to that. I think, it's very hard, isn't it? Because then you need to think originally, was the EGFR low because of a transient cause? Did they have, a big meal the night before? Did they go, did they go running or whatever, or were they dehydrated? So I think that's very difficult. So I think I'd probably have an individualized approach to that patient and look at what their trend is. And do they have any underlying risk factors for CKD? Do they have diabetes? Do they have severe hypertension, etc.? But I think if the EGFR is persistently recovered and it's now absolutely normalized with no albuminuria, I would still want to monitor them, but I would be very tempted to take them off the register. And of course, the EGFR is not a perfect test. It's imperfect, particularly at higher levels of EGFR. So it might be a calculation error rather than actual true CKD. But I'd be interested to see Sarah's view, because she's more of an expert on this than I am.
I would agree. That would suggest to me that there was either a sampling error on the day, and it was more likely to have been a transient reduction in their EGFR. And just I'm sure you're aware of the importance of asking patients to avoid either protein supplements, creatine supplements, and a big steak or beef goulash the night before, getting the blood tests done. That can actually cause an increment in your creatinine by about 40 points. So it's not small amounts, would then probably tip patients from one GFR category into another.
Right. That's really interesting. There were some questions actually earlier on in the chat about creatinine that Raj very kindly answered. Brilliant. So we haven't got any more questions, and we're coming to the end of this session. So I just want to finish off by thanking you both again, Raj and Sarah, for your contribution today. Just to let people know that we have another session in this series, which is coming up on the 23rd of April. And this is going to be focused on CDRC and digital systems that allow us to identify those with chronic kidney disease. So Gareth Forbes is joining us for that, and Alex Wood from the Clinical Network, one of Sarah's colleagues. So please scan this QR code if you want to register and get more information. And then finally, just to say that we'll be sending you a survey, so please do let us know about this session. Any other topics in the field of CKD or CVD that you'd be interested in hearing about, and we'd be delighted to do our best to put those on. So huge thank you, and enjoy the rest of your day. Thanks very much. Bye.